Would you have clinical equipoise in randomizing a 65-year-old healthy person to surgical repair versus clip? Would you have equipoise? Equipoise means you go to the patient and say, I think it's reasonably equal to have either.
Or you don't know.
No, would you have? Like when you go, whenever you randomize a patient in a trial, you only do that ethically if you think there's a clinical equipoise. You cannot randomize a patient. Right. So, for example, would you randomize a patient to parachute versus no parachute from dropping from the sky? Right?
I don't think that's
No,
what
no.
we're asking. It's not the
Right.
same
So you
question.
wouldn't. You wouldn't because you know this. Similarly, when you take a young patient at this moment of time, do you think there's an equipoise in randomizing a young patient? I'm asking this question. Bob, would you like to answer that? Would you?
No,
Okay, you wouldn't. All right.
I think
You're asking,
surgery is very dependent upon the surgeon. Much more dependent than the clip. I mean, I've been in San Raffaele for 23 years. I saw Alfieri. If I had a degenerative MR, I will not go for clip. I go to Alfieri.
Okay. So you
And
would not have a.
I will not.
Question.
No.
The answer is no.
Yeah.
Okay.
So the answer is you need to refer your patient to the best surgeon.
Right. No, that's okay.
And if I could do that,
You know,
if I could do
Sadhu,
that,
and the best surgeon will not take part in the trial.
No, that's my point. My point is that. Greg, would you, 65-year-old guy, would you randomize?
Not yet. I'd want to see the result of the intermediate risk trial before I went down to low risk.
I have many of these patients, and David Adams sees them.
So you wouldn't randomize this patient?
I would have a hard time, because I have David Adams.
So I also want to go back to one of the graphs that you showed. Can you show the graph difference between 2+ and 1+?
I'm not convinced that. And honestly, I'm not
No, actually,
convinced that
go
our
back to that
current,
slide. Sorry.
yeah,
Go back to the slide.
Cyball,
Yeah.
I'm not convinced that our current mitral valve technologies with the clip are anywhere close to the art of what goes on in the operating room by the likes of Dr. Adams.
So therefore, you would not randomize the patient, right?
I think part of the problem I see is that we're overly focused on MR and not adequately focused on the risk to the patient. So when you have a trial that includes low, intermediate, and high-risk patients, I'm convinced that having less MR is better, and I'm also convinced that in a very low-risk surgical patient, you will be able to achieve better MR reduction than with MitraClip.
Yeah, and how?
So for the low-risk patient, let me finish. For the low-risk patient, I don't have equipoise to enroll in this trial. And for the high-risk patient, I also don't have equipoise because I worry about the surgical risks. And that's why when you put all of these together in one trial, I think you will be, at the end, left with reinforcing what we already have. And that is surgery reduces MR better than MitraClip, but surgery has somewhat more risk, especially in a high-risk patient.
Howie, I think if cardiologists in the United States were listening to you, that graph would
But
not look
this is,
like
I
that.
didn't, I'm not,
So the
this
trial-
isn't what
the
I.
trial is needed.
Well, the trial may be needed for this, but I don't know much about this registry. You know, who's actually in it, who, you know, I agree with you, it looks like they're taking from surgery, but I don't think we know much about those patients, but I also don't think that's what I do. So
Yes, Greg, yes, please.
it's a different question.
Well, I actually wanted to raise a different point because you both ended up taking the same point. And the reason, David, you made a great point that the TAVR trials were not contentious. But the reason the TAVR trials were not contentious is that the primary outcome in most of the trials were death or disabling stroke. And that matters to patients. There's not a single patient who cares about whether they have trace, 1+, 2+, or 3+ MR.
I don't know how many
Let me
patients
finish.
you see.
Greg, I
Let
don't
me
know what
finish.
group we're talking
Let me
about.
finish. It doesn't cause tinnitus, okay? It doesn't cause them to have symptoms. It's a surrogate endpoint. And there's been one randomized trial of moderate MR. That's the surgical ischemic risk
So it's the man
trial.
with powder and tie trial on
Okay?
troponin.
So
Like, really?
I agree with you. We need to get rid of surrogate endpoints from composite endpoints. I've just written that editorial to Jack. So we need endpoints that matter to patients and matter to regulators. And it's never going to be an imaging endpoint.
Greg, let me ask
It's got
you
to
a
be either
question.
quality of life or better heart endpoints.
Greg, let me ask you a question, okay? You need mitral valve surgery next week. You've got simple P2 prolapse. We screen you in the echo group. We agree it's a perfect. We can do it for you. You decide to come to me. And let's just pretend I'm looking, you're clever, you're a cardiologist, and you're looking at your own echo report post-repair at 30 days. And it says, the Sinai echo, says, yeah, status post-repair, moderate mitral valve regurgitation. Are you going to call me and say, are you going to go look at are you going to have any interest? You're just going to say, I don't even care what my echo says. I feel fine. I haven't been readmitted to the hospital. I didn't even look at my echo. I don't even care what it is. I mean, it's ridiculous, frankly. And I don't use that word very often on a podium to suggest that a patient doesn't care about moderate MR, because they do. And you would too.
No, I mean, obviously, would I rather have no MR than moderate MR? Of course I would. But the most important thing, I've got to weigh that against, well, I decided to go through the risks of surgery, and the risk is more than just a mortal risk. Okay, it's the discomfort and it's prolonged recovery. And there's a reason that I want to do that, and that's because I'm going to want to get the best repair. That's why I wouldn't randomize low-risk patients right now, because I don't think we're there with the MitraClip. But for intermediate risk patients, there is a question of a trade-off of a safer and easier to go through procedure compared to better MR reduction. And we have to answer that by endpoints that matter to patients.
Yeah,
and we've done these, we've done big surveys, David. They don't care about imaging patients. FDA doesn't care about imaging endpoints in general either. They want a minimum quality of life.
But
Greg,
if
why don't we
I
get
can-
rid
if
of
I can
all-
if I can just say that when patients go in, and I know what you're saying, Greg, in terms of, do they know, is it 1 plus 2 plus 3 plus MR? But when a patient goes in, because they know they're going in because their valve is leaking, the first thing they want to know is that, did that surgery fix my leaking valve? They don't, I'm telling you, that is what they ask. That is what they want to know. Is there any more leakage? And if there's leakage, they're going to be like, what does that mean? I just went through that whole surgery and I still have leakage. I'm not so sure that they think the same about the transcatheter, because they're older usually. They're like, am I feeling better? Am I going to be less in the hospital? But I can tell you, if they're undergoing surgery, they want to know they got that leakage fixed.
No, I don't think that's what they want to
Greg,
know.
when you
That's
say
not what they want to know.
when you
Totally
say
disagree. They want to know, is their prognosis better? And you can't yet tell them, because we don't have the data, that if they have post-procedure 2 plus MR, whether it's MitraClip or surgery, whether it affects their prognosis. In fact, we have one randomized trial of 2 plus MR, and it's
Greg,
negative, and it's a surgical trial.
Hey, Greg, I remember something Ram Tolo said once in one of these rooms. He said, I don't need a randomized trial to choose what I'm going to have for lunch. Like, I know your whole life revolves around this. If it's not a randomized trial, we can't make a decision. Well, guess what? The preponderance of evidence, and I don't have time. I've given this talk for 25. Why do you think Dr. Leon changed his mind? I had 25 minutes to give that talk once. So when you look at the data, the weight of the evidence, there's a good reason why durable repair has been defined for 25 years as 1 plus or less. And I am sorry, you don't need a randomized trial and all those poor patients to go through that to prove it all over again. And if we find it as another follow-up, fantastic. But this idea that we're suddenly going to lower the bar, it's just not what we do in this field. And as I was saying to Joanne earlier, in robotics, that was your same logic. Hey, the pain, the trauma, the recovery. Now we do robotics. It's less painful. It's less recovery. Well, you know what? We didn't lower the bar. We didn't say, yeah, but now that you're not having an open, you're having robotics, well, you can now have moderate MR because you had robotics. You recovered faster. You played golf 2 weeks earlier. My gosh, of course it was worth to have more MR. It's just those arguments, if you say it out loud, it doesn't make sense. And I'll go back to what again, we say it every day in my office on Wednesdays. We treat patients like we treat our own family. Operate, as we said in Carpenter's book, operate like you would be operated upon. And there's no one in this room, and certainly no cardiologist or cardiovascular specialist in this room, that wants to undergo something and get moderate residual anything. I don't believe it. And they don't, and you don't, and these patients don't deserve it. And it's all about something else. And Howie, when you talk about the expectations for different risk patients and equipoise, well, you don't go in trials, you don't have equipoise to talk to every single patient about. You're nodding, but that's not what's going on. If I show up and I'm 65, oh, you're getting surgery. But if some other patient shows up and they're 65, I've got this trial I want to tell you about, and it's not right. And we should have endpoints that we feel comfortable about that will randomize every patient for. And I'll just highlight and finish with what Joanna's comment about a paper coming out in JACC in the next few weeks, which I had the privilege of writing the editorial on. We're chasing something that is the mirage, you're high risk. You have to get to the 92nd percentile of patients to get to a 2% mortality. As Joe said, the median was 0.54, and if you're at 65, by the way, it's 0.3. And this is all 800 hospitals in America, including hospitals that do one mitral valve repair per year. So we do not have a safety thing. And Greg, I'm sorry if it takes 3 or 4 weeks to recover from heart surgery. That's not a reason to now do experimentation on whether a moderate MR matters.
Can I just let Bob respond?
David, if
Well,
the
always
moderate
very
MR
patient.
doesn't change my prognosis, I'm not going to care. I'm
It does change your
absolutely not going to
prognosis.
care. You don't know that yet. Do the randomized trials with hard endpoints and then prove superiority. That's our standard for almost every regulatory device and drug in the United States.
Bob.
Can I ask you a question, David, regarding composite?
You can, hold on, you can, but I want to hear what Bob's going to say.
Well, no, I was just going to bring up the other elephant in the room, and that is, okay, you have good results in that place that does one mitral valve repair per year, but that place is probably doing a lot of mitral valve replacements. I mean, you showed data from New York. You know, most patients don't get repairs. I mean, the STS data, at least maybe it's been updated, but when GAMI published in 2018, 4% of hospitals doing mitral valve surgery were doing more than 25 per year. And if you're doing less than 25, it was kind of a coin flip whether it would be a repair or not. So there's a lot of ways for mitral valve replacement. So it goes back to Antonio's point. So is a good clip, a successful clip, better than a bad repair or better than a valve replacement if you go to the wrong surgeon? So not everybody in the U.S. can go to see the surgeons in this room.
But that's the thing, they actually can. It's one of the most elective procedures possible. There are enough good surgeons that can do good repairs that every patient who needs a good repair can get to one.
I understand, but sometimes your insurance won't let you travel to Cedars, you know, and you're in network, and you don't know because your cardiologist said, I'd like to send you to my surgical colleague down the street here who's really good at doing mitral valve replacements.
But that was part of the thrust of the talk this morning. Our onus is to do exactly what David Adams helped the AHA do and help patients identify for themselves the importance of identifying the right center to have their mitral clip or their surgical repair, and to identify which centers are the place to have them.
Well, it's a great idea, but there's surgeons in my hospital that I would not send a mitral repair to, who cardiologists send those patients to those surgeons. And I tell my faculty, you know, if you're not going to be good at this, don't do it. Find something else. It's really hard to convince young surgeons who are trying to generate RVUs not to do that mitral valve repair. It's sad, but it's true.
Mike, the answer, though, is not to punish the patient for that. You're right. Those patients deserve to know who's doing their operation, and we should be more transparent about outcomes. But it's not fair to punish the patient and say, you know what, since we're not going to change how we refer patients, we're just going to let you have worse regurgitation.
David, you and I agree on that. The problem is that's easier said than done, because I cannot go tell a surgeon, you cannot do that. You know, I can tell them that's a bad thing to do, but if they go on and do it, I can't physically prevent them from doing it. And I see people sent for surgery to surgeons who are good surgeons. They're just not good at that one thing, and it's really disappointing.
Roxanne, I know you want to go on a break, but I'm going to ask Greg.
Yes,
I
we
know,
can go to
but I'm going to ask Greg
break.
one
We
more
continue.
thing.
We can-
No, Greg,
Yeah.
we're going to get one more thing on the record because I want to hear your answer. Your logic was, we don't know whether 2+ matters or not, therefore let's let everybody, we'll find out what happens in a trial, randomized trial, we'll get our data, and in 5 years we'll have an answer. Okay, I love that idea. I'd like to see that too. Let's start with the patient deserves mild MR, which has been for 30 years how guidelines were invented and what we've talked about in mitral valve disease. And we'll get all the data because we'll have core lab echo, and then you'll get your dancer in 5 years. You'll have the randomized, you'll have all the data, and we'll see whether 2+ matters or not. But why would we the patients are the ones that are taking the risk. Why do we change the goal for the risk for the patient now? Let's collect all our data, and then we'll see what happens. Why do you think less patients will enroll if we say, you know, we have this great result and this okay result? We want you to go in the trial and we're studying okay. Unless you want great, then you can have surgery. It's illogical.
So let me respond, and then we got to go to break. So you can't turn associations into medical fact. And I'll give you, I can give you 10 randomized trials that totally spun our preconceived notions on their head. And one of them, for example, was the ACCORD trial. You take diabetics, the lower the hemoglobin A1C, the better survival in those patients, right? So they randomized patients to a low hemoglobin A1C or a moderate hemoglobin A1C, and the ones that were randomized to a low hemoglobin A1C had higher mortality. Okay, you can't look at associations and say that that is causality.
Greg, I agree. What I'm saying is, why change the bar till we have the evidence?
Well, but I can. You have a negative moderate MR randomized trial, number one. You have Seibel's data from COAP, number two. And both of those trials suggest that 2+ MR is not such a big deal. So there is a lot of...
Over what
evidence on
time
both
period and
sides.
what group of patients? Over what time? I mean,
Well-
Roxana, I'm sorry. I can't, you cannot tell me that moderate MR, there's no data that it doesn't matter, or why do we even look for it?
I didn't say there's no
Bob,
data, but there is data on both sides, and that's why you need to do a
Bob, I
proper
think you
trial
and I-
with clinical endpoints.
Okay, great time, great time.
You wanted the debate, Rox.